This is April the 2nd, 2001. This is Connie Reguli in Middle Tennessee. And I have with me today Dr. Denise Sibley. She is up in Northeast Tennessee. And she and I met up recently through somebody else in Tennessee who's very interested in medical freedom and some medical choices. And we had the opportunity to have a nice discussion about how actively she is involved in COVID treatment for patients up in Northeast Tennessee. And quite frankly, what she told me was pretty eye-opening. I thought it was something that needed to be shared with the public. She's very knowledgeable about it. Plus, she has her hands in it. And, you know, I always say in law, I'm down in the trenches working with people, and she is down in the trenches. So thank you, Denise, for talking to me. And we are recording this so we can share this with other people. And I want you to just tell people a little bit about who you are.
Okay. My name is Denise Sibley. I'm a board certified internal medicine physician. I've been in the Johnson City, Tennessee community for 31 years, been a physician for 35 years. I was trained at the University of Virginia, both in medical school, and did my internal medicine residency, and then came here. And since March of last year, began treating COVID. And now I'm up to about 670 people that I've treated very successfully using treatment protocols for early treatment, as well as the inflammatory stage, and in the long hauler, long COVID symptomatology as well. So I feel like I've gotten a really good education in treating COVID, and have been able to successfully, with my early treatment, to keep those folks out of the hospital, off the ventilator, and they've not died.
Good, thank
So
you.
I feel
So, yeah, and so let
very
me ask
confident.
you, first of all, how do people find you? You have an active practice up in Tri-Cities?
Yes, I call myself a concierge private practice. So since March, it kind of blossomed into COVID. And so I pretty much in right now doing 12 hours or more of telemedicine COVID. And so that is a telemedicine practice at this point. Um, I've pretty much, it's kept me entirely busy, busier than I want to be, but meeting a need that I feel like I've treated. I am available through one website as well, a physician website that identifies me as someone that will treat, but mainly it's been word of mouth. And traditionally, I've done internal medicine, but from my first two patients that got COVID last March, and then what subsequently happened, as far as my experience as a physician, I really dug into COVID and felt like it was something that I needed to really dedicate myself to,
Okay.
as it was not being addressed.
Okay, so I want you to talk to me about when you said last March, you had your first couple of COVID patients, and kind of talk to me about right there at first, what you saw with those patients, and then as a doctor, how you were processing what you would need to do for them, just on that initial take. Because I know a year ago now, a lot of us who are not doctors were just kind of like in awe. I mean, like all we're hearing about is people dying, and you know, we really don't know much about it. So as a doctor, when you first are introduced to it and patients are coming to you, how are you processing that?
Okay, so in the beginning, I heard the same thing you did. This is a novel coronavirus. We have six other coronaviruses that we know about. They've circulated as the common cold. We've also had SARS-1 in 2003, and we had MERS, MERS, that was also coronavirus. And so when I first heard about it, of course, I was concerned that I didn't know what this meant. And so we in East Tennessee, we kind of shut down things, as most people did. And then as I began to run data, and I had a particularly interesting position because one of my daughters, who's a young lady, lives in France. And so they were 6 weeks ahead of us in their disease. So I was actively following the data out of France very rigorously long before the people here were. And I was running my own numbers for France, for New York, for Tennessee, North Carolina. I was running my own data pretty much every day, and I began to also. I knew that in SARS-1 we had used chloroquine and hydroxychloroquine, and there were papers written about it. And I knew that the French out of Marseille were gathering data, and they wrote a paper early on with their experience. So I feel like I was a little bit ahead of the curve in that way. And so when my first two people had coronavirus, I thought, well, let's use hydroxychloroquine. It's a 65-year-old drug. I've used it hundreds of patients through the year with a great safety profile. And we use it for malaria, for people that go on mission trips. We use it for rheumatoid arthritis, lupus, Sjogren's syndrome. And so that's what I reached for. And I was very surprised when I went to call it in at the local pharmacy, a chain here, that they asked what it was for. And usually that you don't give a diagnosis for your medication. Now, if it's a narcotic, you can't even call it in. They do require a diagnosis for that, but that has to be e-prescribed. So I thought, well, okay, I know the new code for COVID. It's U07.1. It's for COVID.
Mhm.
And much to my surprise, they said, well, we can't fill it for that. And I said, now, do you mean you don't have it? And they said, no, we have it. We just cannot fill it for that.
Okay, so this
Well,
was as early as March of last year,
yeah.
2020?
Mhm.
Wow. Okay, so another
And
question I have about those first patients, though, that would have been, of course, before we were doing test kits. So, so I'm assuming your diagnosis was all just clinical symptoms. How did you
they
even?
had clinical symptoms, and many of them went on to have positive tests, because the test can stay positive for 6 to 8 weeks after your COVID. Um, and so I tried another drugstore, same response, and I said, well, now where is this coming from? And they said, well, the Board of Pharmacy is has prohibited us from giving this for COVID. And I just hung up the phone, and I was very perplexed that I'd never witnessed this before in my entire life. That's something I've prescribed that really cost about $10, was not a narcotic, that it was withheld for some reason. And so I then, well, anyway, I got the patients their hydroxychloroquine. Let's just
So
say
what?
that.
And so what did you? Well, maybe you don't want to tell me.
Well, I knew that one of my friends used that for her condition, and I was going to borrow some from her, because I felt that this was a life threatening disease. And
Mhm.
the Helsinki Declaration says that if I, as a physician, know of a treatment that might work, I am obligated morally, plus I feel an obligation morally, to help someone um, in a life any life threatening situation, if I know that I might have something that might help them. So I
And
felt
this was
obligated to provide that. And so anyway, the long and short of it is that a pharmacy friend at another pharmacy was actually willing to give that to me in the proper way. But if it hadn't been for my friend, maybe I wouldn't have gotten it. But I was determined that these patients were going to get it, and they were older than me. They had comorbidities, um, and I was concerned about them. So I was determined to get it, and they did well. And so that began, but it really began like a head scratching, like, what is going on? I had never experienced that before in my entire life in medicine, that someone would not want me to try a safe medicine that's 65 years old with excellent safety data. Um, so it began a quest of inquiry that I couldn't. What was happening here in the medical community that was censoring me being able to treat a patient in a way I felt I should, because ordinarily a patient and a physician have a relationship and they enter into it, and you are able to prescribe. It might be off label. 1/5 of our medications are off label. That is, the FDA has approved the drug for something, maybe not this problem, but we know it's safe and we use it for, 10 other things. And so 1/5 of the medications we use are off label. So this was an off label indication, but it was an FDA approved drug. And as I've said, I've used it hundreds of times. So it was the first time I'd ever been obstructed in my patient physician relationship for a potentially life threatening situation. So
And
I
those
began,
patients and those patients had a good result, right?
yes. Hmm.
Okay.
Hmm.
All right. So then as you move past March, I assume you're getting more patients that
Hmm.
you are identifying. And
Correct.
I don't
Hmm.
remember exactly when the test kits were available, but I know there were several months where we had patients who were being diagnosed before there were actually test kits. So I
In
assume,
in in March and April, we were beginning to have test kits. So they were
okay.
putting them out, and we had that available, and so pretty rapidly we were able to test patients, and of course then the CDC did say that you could diagnose it on clinical indications alone, but by and large most of mine were by PCR testing, which was the first test out. And so it was slow because we're rural in here in East Tennessee. It's shown the same pattern. It usually comes to a big metropolis area and then filters down into the more rural communities, and that's exactly what we saw. And so we had a slow trickle at first, and then in the fall, and then December, January, February, of course, we hit our maximum cases and hospitalizations and that kind of thing here in Tennessee. And really, the last 2.5 weeks, um, I've seen a huge burden of patients. And even though our numbers here, as far as the Tennessee Department of Health and our local numbers are down, I'm seeing still a lot of need for treatment. And so it's not slowed down for me, but
Yeah, well,
um,
maybe you're just getting popular too.
well,
So let me
I
ask,
think, I think the
and so
general
let me
public.
ask you at some point, because one of the things we want to talk about today is ivermectin. So at some point in your treating protocol and you're working with patients, you decided on ivermectin. So tell me about that genesis when that became something that
Okay.
you thought was an important part of the treatment protocol.
So I really stuck with hydroxychloroquine in the beginning because I knew we used it 17 years ago and it was available. And well, uh, I had to work around how we prescribed it, but we found out how to do that, and I was able to get it. I had some pharmacies, frankly, turn me down, but we were able to get it. And then, really, in the fall, I started seeing a lot of literature come out about ivermectin and some really strong. At first, they were observational studies, then they were randomized studies, and so international and national data became available, and it became a very strong contender. Now, at that point, I actually called to find ivermectin in my local pharmacies because I have prescribed ivermectin as a parasite. It's a parasite and worm medication, and I've used it on several occasions, mainly for folks who have traveled and gotten a strange parasite, or for an extreme case of scabies or body lice. But I've used it rarely, but have used it, and it was always hard to find because people just do not use it. They don't have worms in the United States. Now you can go to Tractor Supply and get ivermectin for your horse and your cow. But I didn't really advocate doing that because I didn't know that it was for human consumption. So people would ask me that as well. But I called around and no one had it here. We did have a pharmacy that began to compound it for us. So we began having a ready supply. And with the data that was coming out, particularly through Dr. Merrick and Dr. Corey, who then went in front of the Senate and presented their data, the data just seemed to be overwhelming, that it was a contender. And so as I had access to it, it's again an old repurposed drug, 45 years old, very good safety data, won a Nobel Prize for being a safe and effective medication. These are both considered essential medicines that countries stockpile um, for future use or emergency use. So I felt comfortable with the data that was coming out, and so I did not devise that protocol. I followed the lead of what others were doing, and so we also collaborated here locally. We began as physicians who were treating to meet, and we had several meetings here locally, and would just compare our experiences, compare our data. How are you doing? What are you seeing? And so we began to collaborate locally. I also began to collaborate with a group of intensivists across the mountain in Asheville. And so we began to share data here, real life in East Tennessee and in North Carolina. And I became very comfortable with the ivermectin as well, so that I had both. And I would, according to the history or where they were in the course of the disease, because I think ivermectin has a more of a treatment that you can use into the illness a little bit longer for different parts of the illness, the viral or the inflammatory phase, or the cytokine phase. So I think it's a little bit more versatile, but I've used both, and I've
And
had
so
great safety data.
okay, so tell me a little bit about that again, because a lot of people who hear this are hopefully they've not even encountered COVID yet. So, I mean, when somebody comes in, are what, and I know everybody's different, just like every lawsuit is different, and you can't tell
Hmm.
me make general
Right.
conclusions. But I mean, if somebody comes into your office or calls or does telemedicine with you, how do you make that decision whether you're putting them on hydroxychloroquine or ivermectin or whether there's a combination, and are there other medications such as antibiotics involved,
Hmm.
zinc I've heard. So when you have that first encounter, what are you looking for? Because I mean there are people out there who are yet still to get it right.
Hmm.
I'm probably one
Right.
of them. I have not gotten it yet,
Hmm.
and I'm over 65, so it's probably lurking
Hmm.
over my head here. So if I don't feel well, and then I contact you, what are you looking for, and what do you want to know from me, and then kind of where are you going to go with that?
Okay, so I'm very much old school. I was taught to take a very precise history and all of their medications, what kind of history they have, and what kind of comorbidities they have, and so I would tailor um, their therapy to their history. Um, I pay particular attention to any lung disease, so in particular asthma, history of bronchitis, pneumonia, smoking, and here in Southwest Virginia, coal mining.
Mhm.
So I pay particular attention to that. I've also had some quite obese folks, up to 360 pounds. And so that certainly is something that I take into account. Immunocompromised. So when they call me, they have either already had a test and they say, I just tested positive and I was told that you could help me, because they wouldn't at the ER, which is often the case. or they have just heard of me and they call me with their symptoms, and they've already gotten their tests. Most people have gotten their tests already. So it feels like a cold. It feels like the flu, sore throat, nasal congestion, cough, chest congestion, fever, headache behind your eyes hurt, you have muscle aches in your back and legs, you lose your taste and smell, about 50% of the people on day 5, and a few people, less than 10%, have some diarrhea. So if they have that symptom complex and they have tested positive, then we go through the history. And yes, I make sure that they're on zinc, that they're on vitamin D3, that they're on vitamin C. And then for treatment, I would add either hydroxychloroquine or ivermectin, and then add zithromycin, which is a Z-Pak. People are commonly aware. And that antibiotic we're using for its antiviral activity in the beginning of this disease. And then I add steroids to that as well. That seems, and some people do, some people don't. They wait till later in the disease, but I've found it very protective for the lung. The big, not only do I want them to feel better quicker, so if I can get them in those first 5 days of their symptoms, and that's where I start. Day 1 is the day you first had a symptom. It's not when you had your test. And if I can get them those first 5 days, I am so happy. So I can help them to feel better quicker. I can reduce their viral shedding so that they're not as infective. And the real beauty of the early treatment is that I can keep them out of the hospital. So the treatment protocols have shown that you have an 84 to 85% reduction in hospitalization and subsequently mortality as well. So the beauty of it is to keep people from dying and going to day 10 to 14. Day 10 to 14 is a very scary time if they haven't been treated, because that's when often people will get very, very sick and have to go to the hospital. So if I can catch it early, I have a very, very good record of keeping you from deteriorating at day 10 to 14,
Wow.
which is when the inflammatory stage begins.
So, and let's just say somebody has not sought treatment, they're just tough and think they can tough it out, because I'm sure there's people out there like that. And they get to a point where they just have such severe respiratory distress that they go to the hospital. So they go to the hospital, and you just now either find out through themselves or through the relatives. So now where are you in this process, and what can you do?
Okay, so once they're in the hospital, I can't really go in and command their care. They are obviously under the care of someone, and so I have been involved with the families. I've had patients actually reach out to me from their room at the hospital. I'm sorry, my phone is going off. Everybody wants me, but so I've had patients call me from their rooms saying, I heard you gave a talk on ivermectin and I would like some. Could you get me some? And because they're not admitted to me, I can't just go in and command them to give it to them. And unfortunately, here in our health system, they do not recognize either hydroxychloroquine or ivermectin as treatment options. And so that's been quite disappointing, and quite a battle that the patient requesting a medication is denied that
Okay,
that
so
option.
all right, so let's talk about that, because again, a lot of us aren't educated. So we're trying to, first of all, educate them on what this process looks like, the symptoms, better to get early treatment than to think you can tough it out. But now they're in the hospital, and somebody either shares, a family member or loved one shares about this treatment. What can the patient do once they're in that hospital setting to try to get that treatment? What are their options at this point?
They can ask for the medication. I know that here, well, in the hospital systems that I've consulted with, which has been here in the Northeast Tennessee and Southwest Virginia, our health system spans 21 counties in 2 states. I know that it's a protocol, and that isn't apparently not changeable. I know that in Virginia, I've also consulted with a hospital system in Richmond, um, and in Greenville, Tennessee, that they have a protocol, and they do not allow either of those medications. So if the patient wants that, they say no, and they will give them the experimental emergency authorized remdesivir, the convalescent plasma, um, and some steroids, usually dexamethasone at 6 milligrams a day, um, and that's that's pretty much the treatment.
And who sets that protocol?
I'm not sure. Well, we know that the dexamethasone came out as a study early on. I believe it was in the recovery trial. The remdesivir was approved as an emergency use authorization by well, it wasn't approved, excuse me. It was emergency released. It's not an approved drug, but that was deemed to be an inpatient treatment, as was the convalescent plasma, was released under emergency authorization.
Okay, so let me ask you the elephant in the
Mhm.
room question when it relates to anything that I seem to talk
Okay.
about, which is money. So, do you believe that the hospitals not providing this or not working this into protocol or not allowing patients to ask for it outright, do you believe there's a money reason behind that?
I don't know how to explain it otherwise. Why would you if you really thought these people, all around are dying, they're just dropping dead of COVID. It's a terrible pandemic. We have to close everything, do everything. But yet in the hospital, I would not allow someone that I thought might be dying to try a $10 medicine that has a 40, 60-year-old safety profile.
Mm-hmm.
I have no answer to that. I have no
So,
answer to that, but we can use the $8,000 medicines just fine.
right. That's kind of where I was
Hmm.
going. So, like remdesivir, who is the manufacturer of that?
Remdesivir, if I recall, is a Gilead product.
Okay. And what about the dexamethasone?
Dexamethasone is a common steroid.
Okay.
I like dexamethasone. It's been around. The steroids have been around forever, and they're wonderful. Um, I would use a much more aggressive protocol. The protocol that is an inpatient protocol that I prefer, um, and that other hospital systems are using, just not here, uses a very aggressive protocol for folks that are on high flow oxygen and deteriorating. So they use steroids as well, but they just use escalating doses. Yes, I
Okay.
like dexamethasone. Hmm.
Yeah, and again, I'm going to ask you kind of this whole
Hmm.
money, COVID kind of weird thing going on that a
Hmm.
lot of people who are non-medical professionals have kind of seen and they don't quite know what to make of it. So we know that when this first in June and July and when President Trump was in office, it was all about getting basically machines. What are they called? I can't even.
Ventilators.
Ventilators. Oh
Ventilators.
my gosh, thank you. It was just like it's my oldness coming out. So it was all about getting ventilators. We had to use the Defense Act. We had to get ventilators. We had to get ventilators. And then kind of what you heard, what some of us heard, lay people heard off of that was that hospitals were getting a extra check for COVID patients. If they were treating a COVID patients, there was some
Hmm.
extra financial incentive there. So and I don't know whether you know any of that or you feel like sharing it, but again, it's part of this confusion that's laying out there for just lay people. And so what do you feel? First of all, let's just talk about the ventilator aspect of it. I'm 10 days into COVID. I can't breathe. My family goes, you're going to the hospital no matter what. We're putting you in the hospital. Are they going to put me on a ventilator? Is that what they're going to do?
Well, originally, that's exactly what they did, and that proved to be actually not beneficial for patients, and they admit that now. The initial, especially in New York, experience was that that was not the right thing to do, and so they really try to use high flow oxygen or pressurized oxygen through BiPAP and different means like that, and use the ventilator as the last resort. Now people do still go on ventilators, um, but we do not resort to that at first. We allow sort of a passive hypoxemia. We allow their oxygen to get lower than we would normally, um,
Mhm.
because we know the ventilator is not helpful, and in fact can be detrimental. So a lot of the early deaths that and I'm not the only one saying that in New York were because of the ventilator.
Wow.
It was and they just maybe they didn't know it was new, and so that caused more harm than good. But
And and
yes,
so what
we.
is and so once let's say again, I'm in the hospital, I'm pretty serious, having respiratory issues. What is the difference between how ivermectin and the remdesivir is going to work on my body? What is the difference in that? Can you tell me?
Okay, so the remdesivir is an antiviral, again, an emergency new medication that works against the virus. So it would be most helpful in that initial phase when the virus is entering you and entering your cells and multiplying. After that point, it does not help because, um, and my understanding is it's when the virus is entering. And ivermectin, the mechanism of action with zinc, um, it is a drug that also inhibits the virus from entering your cell and then multiplying. But it goes beyond and has some anti-inflammatory action in that next phase of the illness that makes it beneficial for folks even after that initial viral phase. So that even in a ventilated patient, 10 days into it, 14 days into it, I would still give them some ivermectin because of its anti-inflammatory, the cytokine reaction that then comes into play, mast cell stabilization, which is kind of an outpouring of these bad inflammatory things. So there's a use for ivermectin in particular in the subsequent phases of the illness that I would pull it out to use. I think there's no downside to it, um, and so I would say it has a greater use than the remdesivir, and um, it certainly is a lot less expensive.
Okay, so one of the things that we have talked about is what is there some preemptive kind of a legal action or something that maybe people need to be thinking about? And I mean, this is a challenge for me as well. I did look up before we talked today the right to try legislation,
Mm-hmm.
and it's not in every state. Of course, I'm looking at Wikipedia, so I don't know if it's a totally up to date, but it had New Mexico, Kansas, New York, Massachusetts, Rhode Island, New Hampshire, and Delaware listed as states that basically had a right to try law. So I'm assuming that if you're in that right to try law, hopefully those protocols are not quite as concrete, and perhaps patients can supersede or override that. I don't know exactly how that works, and since Tennessee's not in that category, I'm sure you have not run into that. But have you been in situations where a patient or a family member, they really needed to take that next step? They really needed to get some type of either an order or a court action or go above somebody's head or do something to be able to get immediate relief. And kind of how do you feel about that? Where are we on that?
Okay, so I had seen in the media a couple of cases, particularly out of New York State, where a family had insisted that their family member be treated, particularly with ivermectin, and that they required a court order. And so my first gentleman called me from his room in the ICU, just called me on my cell phone and said, "I think I'm dying of COVID. I heard your talk and I would like some ivermectin." And they won't give it to me. And I said, "Wow, okay, I will try to get you ivermectin." And so that began a 3 day battle, really, most of the nights. Um, and the days and trying to so I went through the hospital chain of his treating physicians, his primary care physician, going up the chain of command to the chief medical officer.
Mhm.
I went through the proper chain of commands asking that this gentleman be provided this medication. And we do have a right to try law here in Tennessee, as I understand it, from 2015. And there's also a 2018 federal law that President Trump enacted. And that basically says if you're in a terminal condition, that you have a right to try medication. And so using that right to trial law, we were going to have to take affidavits that this gentleman was indeed in a terminal condition, which we did meet those criteria by the proper people. And it escalated to then where I needed to get some legal counsel to try to get a court order because I met a resounding no from the hospital system. Resounding no, not even allowing the patient's family to bring in the medication independently, even if they would not. They have the medication on their formulary, but it was not approved for COVID. And so I met a resounding no, and sought legal help. The legal exchange, this legal person exchanged um, conversations, and the legal counsel basically didn't want, for this patient, did not want to pursue it further. So I was left kind of without anything to be able to help this gentleman. And he did succumb to COVID. And I felt that the hospital system uh, let this man down. It was, I'm sorry, but I've never experienced anything where you felt someone was dying and you couldn't help them with a simple medication. I'm not that kind of person, so I could not comprehend what was going on. What is the big deal here? Why, why are you not allowing this? Obviously, this man was terminal. He did die. And so that even made me even more as an advocate for these patients, that they be allowed to try. I mean, if we have a novel disease and it is killing people, would you not try anything in your power to help them?
Oh, for
As a
sure.
physician, that's what I was taught to do.
For sure.
Anything. I mean, I can always come up with something to try.
Hmm.
Now, I'm not going to give them something that would hurt them,
Right.
but when you have something safe, why not? And you have studies that say it's helped people. I mean,
Hmm.
published studies. We're not just saying that, some crazy doctor in East Tennessee said it would work. We
Right.
have published studies, we have protocols, and I've just it's called, it's not my term, but it's an appropriate term, treatment nihilism,
Mm.
where you just throw up your hands. There's nothing we can do. He's, you know, He's just going to have to die. And I'm sorry, I don't accept that. I
Mm-mm.
don't accept that. And if the patient is living and I can treat them, I will pull out whatever is in my bag, whatever I know, to try to help them. If it's if it's that serious a problem, I will not stop until I've exhausted everything I can think of. And
Yeah.
to just say, "Oh yes, we have this down in the pharmacy, but sorry, we can't
Mm-mm.
let you use it for this
Not acceptable.
gentleman."
Not acceptable.
I don't operate that way. I can't
Mm-mm.
do that. Can't do that.
Yeah, so we've got about 40 minutes, and
Mhm.
just because of technology, downloading and uploading is kind of about the limit we want to go
Mhm.
to. I think there's much more that I would like to talk to you about on this. And I know before we started recording today, you also started sharing with me that you are now seeing some aftermath of the vaccines, and that is like a whole new topic. So I want to go ahead and close us out for today,
Okay.
and we will work on getting this shared so people can see it. And then also, and so I do want to just, if you could just kind of wrap up with how you and other doctors or your coordination, or your cooperating with just other grassroots doctors, what you are doing in that aspect, and so that people, whoever, wherever they are, kind of know, if they go to their doctor, should they call you? Can they call you directly? Are other
Mhm.
doctors catching on to that? So just take a couple minutes and kind of wrap that up for us.
Okay. So there are thousands of us physicians across the nation that do feel that there is something to do to help people with COVID. And some of those organizations, the American Frontline Doctors, have a website that you can have a telemedicine visit with their physicians that will prescribe for you. The American Association of Physician and Surgeons, AAPS, is another website. The American Frontline Critical Care, um, and that's one of the places that we use their protocols extensively. Um, there are physicians in, I would say, just about every community. We are censored, we are harassed, we are bullied, um, we are, well, we take a lot of heat for it. There have been some physicians that have lost their jobs. There have been some physicians who have frankly lost their license. I think some of them have been able to get it back, but um, we take a risk for going against the approved narrative, that there's nothing you can do, and you only the vaccine is the only answer, and the experimental products are the only answer,
Yeah.
which is not true.
Yeah.
So I'm happy to help anyone that calls me, and I have a website, DeniseSibleyMD.com, pretty easy. But the American Frontline Doctors have a website that's up and running, and they've helped a lot of people. There is early treatment, there's preventative treatment, there's post exposure treatment, and we have a lot of reason to have hope that we can do something besides experimental project products with this
And that we can
virus.
have a life close to normal again,
We
hopefully.
can have a life. I've been living life normal for a year,
Oh,
and
yeah.
here I am.
Good.
Okay.
Okay, well, you have a good weekend and a good holiday, because we have a
Thank
holiday
you.
upon us, and we will talk again soon.
Thank you, Connie. Thank you so much.
Thank
Hmm.
you.
Hmm.
Bye-bye.
Bye.